the patient has a renal pelvic stone with a fairly dilated pelvic elysial system. So I'm going to run us through the entire procedure, what we're going to do stage by stage before we start. So you can see the patient is positioned. So let me first say that the first step in doing an effective PCNL starts from studying the image. So you have to thoroughly evaluate the image. So they are going to focus on the screen now, on the laptop. So you must have, you must be able to view the image in multiple views. Okay? If you look at the screen, we have the coronal view that shows you the stone relative to the pelvic elysial system and the kidney. So we also have the sagittal view. So and you are looking for possible retrorenal colon, it must be emphasized. If you have a retrorenal colon, that can be a danger sign. Okay, you can easily puncture it and you can have fecal fistula and all of that. So you need to do that. Then you come to Ecirs too. So it's a three-standard system. That's the stone. Okay. So having viewed your image in all these dimensions, sometimes you might need to look at the digital subtraction, which is usually the last. I hope it's there. Okay. So the digital subtraction image gives you a fair idea of the pelvic elysial tree. Okay, so yes, sir.
Looking at that stone, it appears there are a few extensions to improve the way your access. It's not an excuse.
So if you look at, you see, and that is why I was saying that looking at the digital subtraction image helps you a lot. Because if you look at the digital subtraction image now, it's showing us that the renal pelvis appear bifid. Okay? And the stone is like sitting air. So we don't have any business with the upper pole. So our business is either a lower pole puncture, then most preferably a middle pole puncture. The middle pole puncture will give us access to the bulk of the stone, access to the PUJ. Should we have any fragment going down the ureter, we can actually chase it. If we have the benefit of, we have the full armamentarium and skill set for retrograde access. So Dr. Lawa can actually help me flush any fragment that is only below, flush them up, and I will just retrieve them through my ampler sheet. So you can see doing a safe PCNL starts from reviewing the image. So you must have a DICOM viewer on your laptop that affords you the opportunity to be able to see the patient, see the image in coronal view, axial view, sagittal view, and be able to give you digital subtraction image that will help you, that you can rotate back and forth to have a fair idea of the pelvic elysial trace. So that is the starting point. So having reviewed the image, then we come to the setup of the theater space. So the setup is.
Can you tell us the choice of the procedure? Why did you choose a mini PCNL or a combined procedure?
So mini PCNL, all the guidelines, AUA, EAU, they are unequivocal about the choice of PCNL as the first line treatment for any stone above 2 centimeters.
That is true.
So, and we know that miniaturization of PCNL helps to reduce complication. Okay, because there has been correlation between the size of the tract and the possible complications.
That is predominantly the kidney tissue damage.
Yes.
Renal nephron loss.
Yes. And also infundibular injury.
Yes.
And so many other things. So
possibility of AV fistula.
Yes, yes. So miniaturization is key. So and that is why mini PCNL reduces the complications associated with PCNL.
Any disadvantage compared to the stone body?
So the disadvantage is that you might spend longer time, okay? Because if you do the standard PCNL, you have a wider channel, you can easily use little class, bigger fragment, and then you finish the procedure quick. But with advancements in high-powered laser and all this equipment, you know, you can do the quick work in minute percent too.
What stone body would you recommend? There should be a borderline between where the patient is like
So it depends on the experience of the endourologist. But I must say that when you see a full sternum calculus, you should know that it's better to go.
Thank you very much.
So let's run through the theater setup. So the theater setup, we saw that. Please give us a panoramic view, wide, broad view. So the first stage is to, and most key opinion leaders will agree that the first stage of the procedure, because I'm describing probe, there is supine and all of that. So I'm doing probe, mini PCNL, with possible probe endoscopic combined intrarenal surgery. So all the key opinion leaders will agree that the placement of ureteric catheter is mandatory for so many reasons. The pacification of the pelvic initial system, then it gives you easy retrograde access. So you need to stop, convert, put your stent and all of those things. Then the presence of the ureteric catheter within the ureter helps to prevent migration of your fragments into the ureter. Okay, so among so many other reasons, the lithotomy position. So it's a pre-status patient. We will remove the ureteric, remove the DJ stent, place our guide wire, and put ureteric catheter over it, and anchor it to urethral catheter, and then return the patient probe. So I am doing a Bolsterless procedure. Okay, bolsters at the initial stage of our procedures, we're using bolsters. Now we use bolsters, and we are usually very fine. Okay, so the setup is we are doing right. So when we position the patient probe, I will be on this side. Okay, so I'll be working from this side. So the laser is to my right, and the pre-position. The screen is that way. I'm looking straight at the screen because I must see the fluoroscopy screen while I'm doing the puncture, dilatation, And sometimes when I need to get my orientation within the Ecirs system, we go back to the screen. And the C arm, the generator is directly in front of me. The endoscopic tab is also this way. The nurses, they are likely to move their instruments this way when we start filling. Okay, but now we will be doing we want to do the placement of the stent. So maybe after we do that, I will do the instrumentation. And then basketing of that project.
Would you consider another puncture if it becomes necessary? Not go for
no way. Go retrograde.
That's any reason why you are avoiding a lower pole
puncture.
No, I mean not. You see, you don't know what calyx is most appropriate until you do your RPG. It's when you position the patient through and you do your retrograde pyelography that you know which calyx gives you the straight, short, and most access to the stone.
Your puncture site is not cast in stone yet?
It's not cast in stone until you see your RPG.
Excellent.
In the prone position. If you are doing prone, then it's supine if you are doing supine. So
That's
RPG
very
will
good
get.
information for all of us, yeah?
Yes.
So that you don't fix your mind on a particular pole just from seeing the images alone.
Yes.
But you see until eventually will guide you on the best position.
So we're going to remove the stent now. Where I'm surrounded by this one.
Some of
There are so many people. Are we just come back?
Hello, who is come so that you can see?
Okay, it's not. Oh, okay. Oh, the two prongs, not okay. Okay. Yeah. Stop.
Can you see the stand?
That's true. No stent. Okay, you just there. The two prongs and then one.
what's the reason for this squeeze stenting? Is it just release obstruction?
This
Or
is
it
for the
utilize
PCL.
the ureter?
The one we use to put in the dentist.
Just two prongs. Then come the back.
That bypass here.
For PCNL.
One.
Even for everything.
One. It's helped me to backload my wire safely. I try to scope as far as I can get. If I get to PUJ, good for me. I backload my wire securely. I'm seeing it that this is where my wire is.
And can you expatiate on what you mean by loading your wire?
So I scope through the ureter up to the PUJ, pass my wire, my guide wire through the scope, and I withdraw my scope. My wire stays there. Then the second benefit is sometimes if you are working with multi-Ecirs stone like this one, this was a CT image. That tiny stone may have dropped into the ureter and you don't know. And if you are doing everything, you might be working blindly. So, but when I scope, if there is a stone, there are several incidences where a stone has dropped into the ureter. And we need to take care of that with semi-rigid before we proceed. So routinely for me, I do that. And then those are the reasons.
Just to pass a guide wire, pass your urinary catheter, for you to have access to inject your contrast. That's the test. Well, I think this is just peculiar to him.
No, not just me. Many people do that.
If you have fluoroscopy,
Exactly.
do you still need to do
The back.
because
Yes.
your guide wire go up into
You can. It depends on. I'm not the only one that does that.
besides it has a fence, so it's patent.
Several people.
Save some time actually.
Yeah. Well, Professor Ahmed, I think Alabi also doesn't like excessive fluoro, so so this will also limit the fluoro exposure.
That is a very last one. So
Yes, he's still
we
young.
have young people
In
here.
fact, the better the better we have less fluidity.
We need to know the standard.
In fact, the more we have less fluidity, the better because of this radiation.
Absolutely.
This radiation is not just story; it is real.
You told him, you told him, give me to them.
Don't worry.
I've already told him anyway.
Most of these procedures consider advanced. Go to conferences, you watch a lot of webinars, and you see very young urologists doing this almost effortlessly. We know the challenges we face in terms of mature patients, and all that. Most of our hospitals that restrict then of course, we are also forced to do everything.
And I think some people pass the guideline to spend on this because of this one now.
No, by phone.
Prescribed standard. Any other thing what are you doing now?
So he's about doing the back loading through a urine, through a semi-rigid ureteroscope. It's in the ureter. So he's trying to get the PUJ. He's got his zebra guide wire in there. You can see it.
So this.
Into the ureter, all the way up to the PUJ.
Yes, he wants to see the PUJ. Make sure his wire is deposited there and
So
beyond
I'm
the
at the PUJ now.
So he's at the PUJ now.
So my wire is in.
Semi-rigid, isn't it?
Yes, semi-rigid.
So that's another thing. We started teaching in our textbooks, in our training. Semi-rigid ureteroscopy is meant for lower and most meat advancing up to the PUJ, you really get more experience, and at the same time, the anatomy of the ureter will determine how far you can go. And of course, the meal is opportunity.
This is key. Keep down. This is key.
Straightness, yes. It's always straight, yes.
I think we are.
Okay, so you are supposed to confirm the CM, although I'm not sure you can see the screen of the CM from here. So the guidewire got the CP. So he has passed the ureteric catheter over the guidewire. So what he's doing now, he has passed the urethral catheter and is anchoring the ureteric catheter to the urethral
Is
catheter.
there a way the audience can see all this? Because this is what we are here for.
Okay, yeah, you can see it. So
You just want to come and
Please give us one after them. That's why she's here.
you see, because of the
Our catheter.
See something that looks like this, the long-J stent or
He has the ureteric catheter.
urinary catheter, right?
Yes, and he's now anchoring, he's passed the Foley catheter into the bladder. He's anchoring the ureteric catheter to the Foley so that the catheter doesn't go when the patient is turned over, rolled over.
This is a very common step.
Put on the
Okay,
hand now.
it's not taking it as it's common step for you.
Okay, make them they see what they do. Sorry, they are videoing from
Put the two together. There.
So he's using a suture. Dr. Lagwe, what suture are you using?
Any switch off.
Sorry? And the explanation Alabi has given is that the collecting system starts filling from up when you inject your contrast.
Well, it prefers to feel from up.
Yes, he prefers it filling from up. So he puts it to the upper pole.
Are there other locations?
That's the usual. See,
Okay, yes.
a small arc.
You can go to the other side of the patient. Just the side the patient's neck.
So he's trying to pass the uretary catheter through the Foley. So there's a trick here.
The catheter through the Foley.
Yeah, so that there's one drainage. You don't want the uretary leaking from the other side and Alabi, how I'm speaking your mind.
Yes, sir. Exactly.
So he passed the uretary catheter
Yes,
through the Foley
exactly.
into the outlet cracks
Yes.
so that he can attach aerial bag, right?
Yes, sir.
Exactly.
And avoid falling the wrong place.
Yes.
Makes a lot of sense. Quite innovative. I like that.
So, urine bag.
And I mean, still
Urine bag.
innovations actually.
My own Alabi, I now when I got
What are we going to do?
So we're done. Let's keep it. This rainbow towards the surgeon. 30 degrees rainbow towards the operator of the CM. Then those are the positions. So
now.
yeah, so rainbow, listen. I've seen this yam has limitations and you're taking. So what I want to do is either 20 degrees towards the end of the patient. Because it's when you have two views that you can get your depth. You can't get depth if you can't have two views. So try, let's see, 20 degrees or 30 degrees towards the end of the patient. I need this to know whether my depth is accurate. Okay? If it's not accurate, you come back to 0 and try again. You go and I will see whether I'm. So if I need to go deeper or more superficial, that's how we get it. There are different ways of doing it. It can be 30 degrees towards you like that, but I prefer this. So we can also do bullseye, then it appears. We'll see whether this can do it well. We'll see. So it's very germane. Except they can get us the bed extension. We can't do that. So yes. So it's not everything, just getting it.
Now, why you are growing, Alabi is in charge, he's the one speaking. I'm the chairman, I can come for 10 minutes. So Alabi, you go on. But I want to quickly say something. Now, quick point. Anybody that is preparing for a C-arm, please troubleshoot before you start preparing cases. You must go and do what you call it now in English. So you have to do dry run. You have to do it. Remember what happened in Jabi? You understand? You must look at your system, make sure everything is working, you do everything. Before you start putting cases together, get your radiographer, tell them make all these movements, speak to them and all that. So when you start the procedure, it's one step to the other. They are basic steps, all right? So very important. You don't want to do your full setup. You never know your table will not go up, or you can't put your patient on the table properly and all that. Alabi, please go ahead.
Yes, so the positioning is prone, split leg positioning. Okay, so there are very important points. We are not using bolsters. Okay, it's a bolsterless procedure. The anesthetist must use face protection. Okay, there have been cases of ocular injury, ocular loss from positioning. So the face has to be well padded, and I always emphasize that in the anesthetist. Okay, so that you don't also have facial palsy and all of that. So the split leg positioning is if we need to go retrograde, we are already prepared for it. Okay. So, and then in between, you can put contrast retrograde.
Right? Legs are so that you can access the.
Yes. And the key about the split leg positioning is that the phallus must that you'll be able to pull it and have straight and easy access. So now the landmarks are the iliac crest. Okay, this is the iliac crest.
That's where your pen comes in. You draw the iliac crest, the 12th rib, the 11th rib. This one is in relation to which of the ribs?
It's a 12th rib.
It's in relation to the 12th rib.
So that's one of the important markers. Surface marking.
What did you just mark?
The iliac crest.
Okay, interesting. The iliac crest.
Okay, so the paraspinous muscle. So this is where you have it.
Okay. Sacrospinalis.
So then the 12th rib, very important landmark. Okay, so this is the 12th rib.
So the line
Rib. So then the posterior axillary line. There are all sorts of opinion about it. People say you should draw the posterior axillary line with the patient sitting or standing in neutral position even before you do your procedure. That's when you'll be able to get where it was. Once you position the patient prone, it changes. So, but let me tell you, even if I don't do marking, I can do a safe procedure. My landmark is the 12th rib. The tip of the 12th rib, never go below it. Never. So even if your posterior axillary line says this is where it is, never go below the tip of the 12th rib. In fact, I give it a bit of clearance in my puncture. So that's the only way you'll be able to avoid. That's the only way you'll be able to avoid your most appropriate calyx. The 12th rib gets in the way. So there are maneuvers you can do to be able to go around it. So we just clean entirely up to this place. We prepare this way and prepare the phallus and all of that. So initially we get a drape that we put under to secure this. Then we put on our TUR drape and bring the phallus through the hole like that. So on this side, I'm going to cut a space in that TUR drape to give me access to my field. Okay? So the entirety of the drape goes to the anesthetist to screen us away from the anesthetist. So I will do my puncture. Once I get the puncture right, I will dilate. Once I dilate, I'll put the amplats. Once I put the amplats and the guide wire, I will then get a fresh broad drape that I will pass. I will make a hole in it and I will spread it over. Let it fit snugly around the access sheet so that the fluid, I will fold it around so that the fluid I'm making will be coming straight into the bucket so that I don't, flood everywhere irrigation fluid.
So that's good. There are some special PCNL drips. There
Yes.
are PCNL. Please go ahead.
Yes, so we are about doing the dripping. So you can see we have to insert the star drip underneath to shield the phallus, to bring the phallus out, so that we can access it without contaminating ourselves. So this, the TUR drip, the arrow is pointing up, so you place it this way, then, so that you know, this goes this way. Just hold on, we need to adjust.
One of the ways you know a good surgical tutor is that when they are going through the steps, they want the people they are explaining it to understand what they are doing. I think Alabi meets that qualification. I think I'll be speaking for everybody if I say that it's a good surgical tutor. Because he tries to be didactic and make sure people understand what he's doing. Alright? There are sometimes you see this procedure, you just go you won't know what the person is doing.
So it's a good teacher.
I usually cut this so that it can go. So that you can have enough food. So this usually drops. This will drop. So Taran and see what I was saying. Follows through. So the phallus is, so we don't pull, we just drip this way. So with this, the handcuff, we then spread stuff for the. So that's just the cut so that we can easily palpate our landmarks.
Now, while we are waiting for the next step, can one of the younger consultants please Google patient positioning in PCNL? Alright? Patient positioning in PCNL, in pro PCNL, and share the images they can see on the WhatsApp forum for this meeting. One of the younger consultants. So please Google patient positioning in pro PCNL. Well, they know themselves.
You are one of the younger
Dr. Amus has become
So we can get another one.
yes. So we are getting it fluoro in. What our tray looks like. Okay. So for our scopes, semi-rigid, 7.5 French. Then the nephroscope. The semi-rigid has finished its function. Okay, that's what we used to place guide wire and then subsequently ureteric catheter. So we're going to be using the mini nephroscope.
What French is that? What size?
By Carl Stoss. 12 French.
12 French.
Okay, they actually call it pediatric nephroscope. So that it's mini nephroscope. Okay, so beautiful and then very expensive.
8 million.
Okay, so that's the miniscope, 12 French nephroscope.
So, yes,
Yes,
in
8,000
my
I see the
practice,
pictures.
this is the IP needle. This is puncture needle. Okay? Where is it? So this is the IP needle. This is 2 parts puncture needle. Okay? There are 3 parts and all of that. But I use 2 parts. And this is size 22, I think. Okay? So the idea is the puncture. This is Cruz. It's one of the best. It's arguably the best in the industry. No conflict of interest. I don't market for them, so and I don't represent them for anything. But in my experience, it goes in smoothly. The puncture is good. So it's 2-part needle. Once you are in, how do you know you are in? We'll talk about all that.
What makes it 2 parts?
2 parts.
Yeah, once you remove that, the fluid that you talk about will come out. Yes.
The
Troca.
The
trocar.
trunca, the cannula.
So 2 parts. So this is it. So this is the puncture needle. So once you are in, you pass our guide wire. So my preference is zebra again. Zebra 0.038. Okay.
Do you use any other type?
Yeah, different people use whatever works for them. But
The
this works for me.
sensor wire is very good.
So now,
It's terrible that slips out.
in my practice, I use Alkin's dilatation system. Okay, I use Alkin dilatation set. So and this is the rod. Okay, so once I get a good puncture, the first thing I do is I use this. I dilate with this. This is very easy.
Now,
You can go to any.
Before that, let's see the other
Is that a
components.
facial dilator?
The other components of the alkene dilator is there.
I'm
So
coming.
they do
The
that.
reason I'm doing this is, by the time I'm doing the instrumentation in such a way that the flow follows how the procedure goes. So you'll be able to relate. Not that I mentioned individual items. So I puncture with the IP needle. I put the guide wire in under fluoroscopy. The next thing is I dilate with this dilator.
Is that a facial dilator?
No, it's just size 12.
Or size 12 dilator?
Dilator is a set.
For a mini PCNL, you don't need facial dilators, right?
You can do facial dilator. That means there are different forms of dilatation for PCNL. There is serial dilatation. That's when you use facial dilators. You start from the lower, maybe 8, then you go to 10, 12, on and on like that until you get to where you're going. That's serial. There is telescopic dilatation. I prefer to do telescopic dilatation. The serial dilatation, you dilate, you remove. The area where you dilate formally is bleeding before you get in. So it's kind of that the system gets bloody before you get in. But if you do telescopic dilatation, so that you can use alkins, you dilate. Once your wire is in, once your guide wire is in, you put this rod through your guide wire into the system, and then these are the followers. These are different sizes of the alkins.
Yeah. And if I may just quickly make a point, Professor Alkin is a very big historical figure in the story of PCNL.
Yes.
He started, was it in Germany or in Switzerland? I don't remember.
Germany.
Germany. So he started it, and he developed this. So it's named after him, Professor Alken dilators, ALKEN. All right, but I have to say that the pressure gauge. What do you call that? I used to dilate a spoon.
The pressure gauge. Yeah.
Sorry. Yes, that's right. This dilator. Very few urologists use it now in Europe. But why? Because if you're not very skilled at using it, all right, it can rupture the kidney. And I experienced it in Lagoon Hospital in Lagos about 2014. Now, you put it there, the patient ended up with a partial nephrectomy. All right? Because, yes, that's one of the complications. So, the reason why I'm saying that, and I put it starkly, are you with me, that it is not the only dilator you can use. There are alternatives. So if you are very familiar with, I remember the one I was doing in Abuja, I think that is also what only used. So it's very good if you are used to using most. And what I'm going to, yes, even the one that was done in Sokoto, I think that was what the guy.
Please, let me finish with the dilatation.
So once you've done that, please show us when you are doing that, show the technique very well, because it's cheaper than, because you can reuse it on like that gauge. That gauge, use it once and then you throw it away.
Yes, I will talk about the options. There are so many alkenes. And I will tell you what I also can use comfortably outside of alkenes. So, we've talked about the serial dilatation with facial dilators. Then, the next one is telescopic dilatation. The telescopic dilatation with alkenes, you get the rod in, okay? I first of all dilate with this, so that the rod can go in freely. Once it gets in, under fluoroscopy you fix it. And then you then pass the dilators serially over it. The advantage is, the first one goes in, the next one goes in over it. Tamponading on the kidney. Serially like that, it goes in over it. You are not removing the previous one. So by the time you are through, the kidney is already tamponaded. The point, your chalicia point of entry is tamponaded. So you discover that your feed is clear, it's clean. You are just doing your procedure neatly. So, but like Oga said, you must be wary of overdilatation. What he's saying by kidney rupture is overdilatation. Okay, you are in the calyx. Your rod, the tip of this rod, you can see. It has an indicator. This indicator must remain in your targeted calyx. It shouldn't slip into the kidney. Remain in your targeted calyx. Okay? And the first, maybe this goes over it to stop air. Okay? The next one goes over it serially like that. And you are controlling it with fluoroscopy to ensure that it doesn't go, you don't overdilate. If you overdilate, you are going to go across the infundibulum, share it, and then you can bleed. Okay, but again, the beauty of mini PCNL is that we are using small ampler sheets. So even if you overdilate, it's going through an infundibulum that can accommodate it. So that's one of the beauty, but you must always be careful so that you don't overdilate. That is telescopic dilatation. Then there's what we call since people are moving towards single dilatation nowadays. Okay, so, and we are privileged that Castor has that. So this is, for instance, if I'm doing 21, 22 French, okay, which has its own amplats, metallic amplats. So what I do is, in a single step, under fluoroscopic guidance, I get into where I'm going. You get to where you are going, and then you can then gently move this over it. And let me say that when you are dilating, for you to avoid over dilatation, you don't push like this. You don't push. So what you do, you screw gently, you maintain slight pressure against the tissue, and you are screwing. So this way, you don't accidentally push and you go and avulse the the infundibulum and damage the kidney. So if you do like this, gently under fluoroscopic guidance, and you get to where you go. So after then you put the implant. But okay, you can put it this way. Then you put it goes over down, and then you remove this and leave the guide wire in. Always leave the guide wire in, because sometimes when you get to the system, it won't direct you. Okay, so that is about dilatation. The third form of dilatation is balloon dilatation. The balloon dilatation may not look feasible for environment because it's expensive. Most of them you can only use them once, twice, and they are out. So, but the trick about balloon dilatation is you must preload the appropriate implants on it before you inflate the balloon. Because once you inflate the balloon, the dilatation catheter has a wide junction, so you'll be able to load your implant again. It has to be preloaded before you put. So that's a very critical point. If you miss it, you are going to waste that balloon, and it will not work. And you might even bleed because you have inflated the balloon inside the kidney, it has dilated the kidney. You now have to remove it, put this back, go back in, and all of that will make your procedure clumsy. So those are basically the dilatation techniques. But I will tell you, for practical purposes and for sustainability, yes, I will prefer Arkins. Arkin is my go-to. Then I'm going to use single step. Okay, so yes, okay, I can use it if you want me to. But the thing is, I want to. Yes, it's readily available. Let me tell you, the benefit of the metallic dilatation is, I will in my presentation tomorrow, I will show you how I broke my my nephroscope, my mini nephroscope, completely bent like this. Okay, and that's about $7,000. So this, when this is in, if you need to talk, this helps you to talk and protect this. So that's the benefit of metallic. Since I don't have it, that's why I use all of this. But if you have metallic, I think metallic is it. Okay, so
A quick point about a quick additional point.
It's a basic point. For your initial puncture. Because let's assume if you get into the system and you didn't know, you withdraw, you made another puncture. If you load, if you feel the contrast from below, it will extravasate. And the beauty of the puncture is that so that when you puncture it and you know where you're going. But if you mistakenly enter the system without you knowing and you withdraw your cannula, you have created a point of leakage of contrast. So the contrast will extravasate and blur your pelvic initial system. But if you started initially with a very light contrast, you can add another contrast and reconstitute a thicker contrast, so that if you now pass that, it will pacify the pelvic initial system within that blurry initial blood system. Yeah. So you will see a thicker shadow within the blood shadow. That has happened to me about twice, and with passage of the contrast, a thicker contrast, we are still able to go ahead with the procedure. Another thing you can do is always have ultrasound in the suite. If you have extravasate, pardon me just a minute, if you extravasate and everything is becoming difficult with the fluoro, you can use ultrasound. Ultrasound can guide you to the depth. Okay? We have that benefit in Nigeria. In India, for you to use ultrasound, if you are not a radiologist, you have to be licensed to use it. Really? Yes. The urologists in India don't have free access to ultrasound. Other professionals, apart from radiologists, when you use ultrasound in India, you have to be licensed for it. So that is that. But here, everybody can buy ultrasound. So ultrasound should be, you should add point of care ultrasound to your armamentarium as a urologist. It will be very beneficial to you in so many ways. I think Oga wanted to make a point.
Yeah, no, just before you puncture this.
Some of these explanations can go on as we proceed.
Can you see the mark? Can you see the marker on the skin? Can you see it?
We can't see.
See if you can. It's on now.
Here is dark.
Can somebody take a picture with the phone of this one and put it on the WhatsApp?
You guys
Somebody
don't have to do it over there.
take a picture of that. Can somebody do that, please? Take a picture of the mark on the skin and put it on the.
You know, did it a while ago. Maybe she lost it again.
It's not it. So, no, not yet. You see, he has to take a shot for me. Plain. Perfect. You're a great man. So, listen. Can you move slightly towards me? Just slightly. Perfect. Short. Excellent. So the idea is your needle coming from the side. You need the clearance, and then so that everything is fine. So you see, the build at this stage is very critical. So please, I need the pedal to my side. You know, from the other side, it's like
on the fluoroscopy image screen.
I didn't get that.
Dr. Lawal, can you, I don't know, is it possible?
From the side, you need the clearance, and then so that everything is fine. So you see, the build at this stage is very critical, and we are going to give continuous flow. As Dr. Lawal is opacifying the system, I want to see how the stone fits into the pelvic elysial system. It's very key, because if you opacify the system, it becomes blurry. Okay, so I want to see how the pelvic elysial system comes around the stone. So it has to be continuous fluoro here. So, are we set?
Yes.
So, Dr. Lawal, continuous fluoro. Let's go. Are you ready? Let's go. Let's go. Inject fast. Yeah. Fast. We said earlier. I'm fine. Oh yeah, fluoro, let's go. 15. Yes, can you see? Fluoro, let's go. Fluoro.
1:3.
I'm about to find. Yeah. Yes, go. Yeah, okay. Hold on. So, now, give me space. Give me space. Let me go to that. I want to explain something. Yeah, excellent. Yeah, stop. Continue. Prayer shots. Yeah. Are they seeing it?
Yes, we can see it clearly.
This is shadow of the stone.
Yes.
Okay, so you see how the pelvic elysial system, how we opacify the system and everything was placed in proper context. So that will now guide us which calyx should be our calyx of entry. So if you look at it, our best calyx of entry is this lower profile. Do you disagree? So because you can see it gives us a straight access to the stone, we are going to be able to access the whole of the stone. The only challenge is that we may not be able to talk to see the PUJ. We may still be able, but we'll see. So we are going to do a dual polar puncture. This is also a good puncture. But to get to, by the time you are walking here, some will escape to the lower pole, and you may still be able to walk that way. Then the challenges. So you see, a sound understanding of the pelvic elysia anatomy is very key for you to be able to do an effective PCNL. And so that is what we're going to do. We're going to attempt our point on the calyx. Then this is closer to the, so there's no problem. So what I usually do is I do a gradual descent technique by SK power. So rather than go, if I go through this exact point down, that's bull eye. I will bull eye on that. And if you look at it, that calyx looks like it's facing me. It looks so beautiful, it's facing me. Okay? Because you can see that oval this thing. It looks like it's facing me. So if I bull eye on it, yeah, it might be good. But I would like to come a little here and then go this way. Still on the same line.
Can you see?
Give me the marker.
Cameraman, let's see the fluoro.
No, not the fluoro, the skin marker. You see? Fluoro? Fluoro, give me a shot. Okay, so a shot. So ordinarily, if I go through this spot with a bull eye, I'll be fine. So but I'll go through this. Also this spot, you can see the rib will be my way. So but if I come this way, I can do what we call gradual descent technique by escape power and then access that. Okay, so and that's what I'm going to do. I hope for the best. So, no, I don't usually make the marking on the skin. I don't usually cut.
That's why it gets fluoro.
No, that's it. That is me against fluoro.
Yeah, you are in. That's excellent.
You can see the movement. So what you can see where my no, give me a shot. Give me a shot.
How do you compare your depth?
Give me a shot. You see, look at the orientation of my needle. See the movement of the kidney. I should be within the system. I don't know. We'll see. I may try by removing my cilia to see. So you give me, so I may try. Contrast.
The needle is there. He's trying to see now if it's there. Now, methylene blue is
So
very good for
I'm
you.
not there. So
Methylene blue. You have methylene blue. You don't
so we use the second plane to get our depth.
You can just see the blue fruit coming out of the middle there.
So 30 degrees towards the edge. In both planes. So maybe a little maneuver to maintain the pressure inside the system.
The interesting thing about what he's doing now is that so that you be parallel to the cable, you think you are listen to it.
Yes.
And that's where the ambulation of the signal can be full.
Then
Yes. So the signal should follow your movement. Should come from where you are putting the needle from, so you are seeing yourself going down. That's the tricky thing.
it's possible. So you see, what we do, I will reorient it in zero. It's always better to reorient in zero and check your depth in this thing. So can see I pushed the stone in. You did see it? Did you see it? You have pushed the stone. Yes. So, just this. I pushed the stone in. Okay.
The stone was blocking it.
Can you see? Under the fluoroscopy, you can see the stone.
Hello, madam. Maybe I should go to this store, young class. Let's use to just hold my wire from
So the key for this ornamentation is to go down until you adjust it before the stove.
You have to under.
So the end that will then support the others following.
The line is
You want to see at 0 or at around
0.
It's not at 0 now.
It's at 0, 0, 0, 0.
You have to refer.
0, 0, 0. Thank you for that. It's very cute. The direction has no screen.
okay, now you can see the rod.
That's the tip of the.
So you have to advance it a little further. That is the rod of the Alcan stylizers.
So very tempting.
Screen. Screen.
Go to 30 degrees this way. Don't forget, this is the
Reduce the light. 80% is too much. Hello, Mr. Bello.
Sure, it's not stable.
Yes, sir.
That should have contained the thing, that helix, and the ureter. And we didn't send any comment pressure facility, so we believe we are in. So right now we are going. In with the nephroscopes. The assistant is doing a wonderful job. He's holding both the guide wire and the ampler sheet. It's very, very important.
Okay.
So it's going in now. You can focus on this. If you look at the monitor now, let me read it from the book. Yeah, I'm going to cut. Now, let me read it from the book. Yeah, I'm going to cut water from the line. Yeah, it's trying to. We're working on that. Hello, water.
Move the CM back a bit. In that same line, move the CM back. It will clear very soon. Don't shake it. In that same line, move it back.
Can you please focus? The image is very poor.
You see, you are not. You see, I'm very
You are wobbling. I said in the same line, move it back.
Okay, so can you see now?
It's not clear.
So that is, no, where you?
That's the stone.
That's one far.
Can you focus better?
You don't trust us.
Can you see it now? So, no minority report.
Spiculated stone, looking at the calcium stone.
Yeah, something like that.
Water.
Can you see it now?
Oh, very clear.
We are trying to get the best view.
Thank you, sir. Remove the
Get wire.
Which one? Yes.
Yeah, the stone is very clear.
That guy is going to be anything else.
Straight doors, please.
Iṣẹ́ mú ṣe wà yìí, mo mú bẹ̀. Ìsọ̀lá ní ọ̀gá ló bá mi lóòdù lé ìjà. Ṣé get?
Charlie, do you want the table to come up a little? Oh, yeah, okay.
So what we do? Ìsọ̀lá ní ọ̀gá so
Yeah, very clear. Okay.
So, like I was saying, adversity is part of endourology.
Absolutely.
It doesn't go like you want it all the time, but you must keep your head cool, continue to work at it.
There are so many learning points.
Yeah, so many learning points. So,
Scissors, please.
So, I will really thank you for your patience. So,
yes. So, God will be coming out.
Just a minute.
now show us the setting.
Yeah, we show you. We are trying to go on.
Okay.
We are starting with.
They can only tell you the setting.
Okay.
The camera is not that.
Alright.
the pedal, put the pedal on the side. Okay, Chief Ahmed. So the aim here is to fragment. Since we have a fairly wide sheet, so we are starting with total wattage of 25, energy is 1 joule, frequency 25 watts. So you can see the fragment coming out already. So if there's a need, you can always alter it. Yeah, of course it can be, but it's like, that would be better if you have a bigger sheet. You know, the advantage of this miniaturized sheet is that you can even use standing panel, which you cannot use with pneumatic. But this one now, you can see the fragment coming out easily.
They are flying out.
But between cleaning effects. With the carbon cleaning effect, so they are just coming towards us there.
He's using the Venturi effect instead.
Yes, sir. Exactly.
Can you see the battery catheter?
We can see. Oh, yes. Talk to us.
Yes, we are making some steady progress. The stop burning is much reduced now. You can see the stop fragment there actually is moving now.
It's moving now.
Yeah, so we're almost done with the procedure. The sheet actually was helpful in this case. If it was a standard PCNL, the people would have been more severe.
The adapter has a way of locking the fiber when you're holding it.
See. Yes. You can see. So now field system. Increasing it. You drag the flash down so that doesn't water. It is there like a cooling box. Your it's going through the dangerous angle. I will see if I can talk to Richie, otherwise we just use the benefit of
from down.
Well done, sir. Thank you.
I'm pressing. Yeah, pressing here to that.
So let's see the up.
Up.
Metron.
Up.
Stone.
Move up. Okay. That's okay. At your. Okay, screen. Okay, so this is good. It remains a tiny one there. Can you see?
Yes.
Yes, just above my little gauge.
Above the.
So let me demonstrate.
They got it much here. They started here.
Can you move closer?
Yes. Yes.
Can you come back?
See, that's
Can you give the
my
camera
flat.
so that you can show them?
That's my carry suspension. So
Flexible from below.
yeah, choose the plastic. Choose the access sheet rather.
Through the outside sheet from below.
Yes, an access sheet.
Yes.
Okay, I guess since there was a double resistance, I mean there was a guide wire installed.
It was a urinary catheter.
I see.
So that's the upper hole. So this one comes through the parallel calyx. You can see the long particular of the upper hole. So you can see this is my amplat.
When you see it now, there is a cone. It's a cone. You pass it on the
Now, you can come down. So you see,
whatever flatness that break,
you come
when you
through.
follow down the ureter, stays there. So by the
So
time
we
you
see each other now. You see? And we are moving flexing up and down.
Yeah, that's it.
Can you see the benefit of combined the water? Yeah. You see, the first pass of ECRS is 100% good. If you are comfortable, do the comfortable procedure with ECRS, the first pass is 100%. Can you see this? What else? So, you can move up to like 1 o'clock now. No, 1 o'clock. Like 11 like that. Yes. This way. Yes, that's my invitation. I'm busy. Laser, please. It's for him. I just go down to the. Let's see if you can get it. That is still there. Yes. So I'm seeing it. It's also
Are you still using the 550?
Yes. 550 now.
Bello, peda.
believe the purpose for which this workshop was organized has been largely achieved. You see a series of places,
Everybody from the first escape from our chief.
Thank you very much, everyone.
Yes, I think you to send that.
None of the ones for the game.
Given set.
So, where talk for me so that I can. That's a flexible. No fire. So, just go in, then the calyx there. Just go in. This is the place I was struggling to enter. Okay, hold on. That's the thing there. Move your scope back. Move it back. So that I don't need to Yes. So, that's how I come in now. So I've been drawn for you. So come in. Go into that, you see, go into the parallel calyx. This calyx is where I was afraid to enter. Because of excessive talking. You can see you have entered it now. So you have entered it. So can we have fluoro? Enter it. Forget one. So now scope inside it to see whether there are space. That is. Yes. I will require excessive ventilation to enter there. I think it has come down. But water, they need water for you there. Somebody, later, irrigation pump, you press, you give him water there.
Please pump this.
That's it. See, that's all. Move down a bit. No. Turn your hand to the right. No. Okay. Yeah. That's also helpful. So you see, can you see? As you irrigate them, they will come to you. You see what I said? So once you go in there, irrigate, flush with water to come to my routine hand. Okay, so it has to come out. You see, you are blocking it without it coming out. And with water, somebody to. So what you do, madam? Not complete babuta. So that come out. You have to come out. Go in again. You have to basket it and give it to me. Hand it over to me. Basket, or Gabelo, just scrub, come and help him with basket. Yeah. Don't put too much pressure. Yeah, this is a single part practice. That's very good. With this one, you are sure of 100% clearance on the table. Would you go and remove it now? Bello, check. Works in this case. So that thankfully is able to. You have to open now. Open the back. There's a small spoon there. Yeah, I can see. So, John, the only shows you are not doing. Did you cover? Okay, all right. Yes, sir. This year, are you covering what you're doing? Yes. How? No. No.
Where is the? I did. Yes, I did. Up to this night.
And give a panoramic view, maybe from there, from somewhere, or from there, from here. Okay. You'll be able to see. The pressure should be less now. Yeah, open it. Just withdraw it a bit, Legs down, okay? Look down, you're looking up. Open, withdraw, you're ahead of it. Open now. We are advanced. Okay, look up a bit, Okay, look up. You are looking down. Drop. Yes. Now come out. Listen. No. Push. Okay. Grab it. So now come out. Come out. No. Look up, flex up. No. You have to go back in. Flex up so that you can see me.
Okay, you want to grab it. Okay.
You want to grab it? No. You can come out now. You want, okay. Yeah, come out. Come out. Yeah, that's it.
Okay, the person will access it.
So please, you must always see what he is. That's how you cause abortion. And you must always see your stool ahead of you. This is the distance. So if it gets looks upstairs, you won't
You have left him again. You're not together. Yes.
Are you coming? So this is a perfect clearance. Focus on this screen. Okay? So this is a perfect clearance. We are done with the procedure. So we just pass our, okay, you can back out. Back.
Up the chest like this. The head.
So, we want the edge of the patient. Good. Perfect. No one, if you can't find though, before corn was discovered, now something.
I felt so bad about this guy. I said, I'm here about 50 years. So, congratulations, sir. That's our I'm a political.
All of us.